ICU in Saudi German hospital, and I'm also visiting professor of neonatology. And today, as usual, on Wednesday, we do neo review sessions, mainly for neonatal fellows, but also for all those interested. And today, it's my pleasure to again host Dr. Monica Kosha. Dr. Monica is a neonatologist consultant, and she's a chief in ICU in Emirates Specialty Hospital in Dubai Health Authority. She's very eager. I can say from my previous experience with her, she's a super good presenter, and she can make her case very well. She's interested in research and teaching, and I'm my pleasure to listen to her with you. And I'm sure almost 100% you will enjoy and learn. So, Dr. Monica, the stage is yours.
Thank you very much, Dr. Aya. We are talking on non-invasive ventilation, and then we are moving forward towards the invasive. And today our talk is on pulmonary graphics. Now, I don't know how many of you are using the pulmonary graphics, but if you're not using, or if you feel it's very tough to use, I hope at the end of this presentation, I would try to make it simpler. And it's really beautiful to use this pulmonary graphics. So I actually, while I was doing my super specialization, my mentor...
Sorry, Dr. Monica, for interruption. Somebody said no voice. I can hear her very well. So she's hearing me, I can hear her. So the problem is from your side. So I don't think we have a problem in the voice. I'm sorry for the interruption.
Yeah.
Go ahead.
So my mentor introduced me to the pulmonary graphics, and since then I'm really using it day in and day out, and I find it quite useful actually in my day-to-day practice. So graphic, like making something perfectly clear, will totally confuse. That's what sometimes it happens, but I would try not to do that. And so when we had days without graphics, what was happening was that we were, the clinicians were left guessing, like what is the tidal volume, what is the pressure applied, is it a gas trapping which is happening, baby's improving after we give surfactant or not. And we subjected our babies to lots of, I think, X-rays and blood gases. So then came the pulmonary graphics, and the old system what we had was quite cumbersome with cumbersome equipments which were difficult to calibrate. They had a lot of dead space. They were big, huge ones, and they actually increased the work of breathing instead of helping. And some of them were only giving us a single snapshot experience, and they were not like complete what was happening before, or we were not able to see. But new ones are really good ones, and they have a microprocessor-based flow sensors. They're quite user-friendly. They can be used on the bedside, and some of us are using for a research tool. And but we do have problem when we have very tiny babies who have very small tidal volume. It might fail to detect that. So that might be a problem. So why do we want pulmonary graphics is because whenever the patient's condition is changing, we should be knowing and identifying the respiratory pathophysiology. And whenever we are giving any kind of treatment, like if I have given a surfactant, whether it worked or not, if it is a BPD, I give a bronchodilator, whether it worked or not, PDA, I've given some treatment, it worked or not. So some objective to evaluate the treatment should be there, and it gives us beautifully. And then like whenever we are going for any workshop for the ventilation, we are told that, okay, if you have HMD, put this setting. If you have meconium aspiration syndrome, put this setting. But all the babies of HMD are not same. All the babies of meconium aspiration syndrome are not same. So to optimize the ventilator performance and to fine tune the ventilator, you need something, and this gives a very good help. And once our baby is improving, and to know that we can take them out of the ventilator, it helps in a weaning process. And if there is any misadventure like tube leakage, or there is blockage, secretion, or tube is come out, these gives us, picks it up quite early on. And hence we can use them to reduce the ventilator-induced lung injuries. We can improve our quality care in the issues. And of course, delay in the picking of misadventure can be reduced, and customize the setting as per the need. So whenever, if you're new to it and you want to choose something to give you pulmonary graphics, you should choose a 24-hour trend, which should be printable, and it should have a direct and online visualization of the 3 fundamental parameters of the respiratory system. And that is 3 are the driving pressure, the tidal volume, and the airflow. So this should be there. So how does the flow measurement occurs? So how it is measured? Either it is measured by the pressure pneumatocatograph or by a hot wire anemometer. These are the more common ones. The others are the people who are using NAVA, they use this orogastric tube with diaphragmatic EMG sensors. The previous old ones like thoracic impedance and abdominal capsules are no more used. And where is it measured? So either it is measured near the ET or it can be measured near the ventilator. I would say the one which is measured near the ET would be the better ones for the babies, small babies, so as to pick up better. Now, what is the principle of flow sensor thing? So actually it tells that the temperature which is lost depends on the flow of the gas. So that's the basic principle. So what do we have is there are 2 tiny platinum wires, and these are heated to 400 degrees centigrade. Now the one wire is shaded to determine so that we know what is the direction of the gas. So from here, the hair gas is flowing. Now the wire cooling will be proportional to the gas flow. Now you have heated a wire and the gas is flowing, so that wire should be cooled. And then the flow is integrated with time, and that's how the volume is measured. So flow with time measures the volume. This is the principle, very simple principle of flow sensor measure anemometer. And most of the ventilators nowadays are using this only.
Can I interrupt?
Yeah.
So you mean, I mean, I'm just rephrasing what you said. So you mean that the temperature change in a distance over time represent the flow?
Yeah.
Okay.
That's what it is. Yeah. And so when the pulmonary graphics, when it is taking out, so some parameters the ventilator measures, and some parameters are calculated out of this measurements. So like we are measuring flow, pressure, and time. And then out of this calculated is volume, compliance, resistance, work of breathing, and autopy. So we should know the normal values. So the dynamic compliance, the normal values, which is change in the volume with the change in the pressure, is 1.5 to 2 ml per centimeter of water per kg. And the resistance is 20 to 40 centimeter of water per liter per seconds. And then we know something like static compliance and a dynamic compliance. What is it like? How are they different? The static compliance is measured when there is no airflow. So it reflects the elastic properties of the lungs. And the dynamic compliance is measured when there is an airflow, and it reflects 2 things: airway resistance and the elastic properties of the lung and the chest wall. So what we see on our graphs in the ventilator monitor are 2 things: the waves and the loops. So the waves are saying something over time. So it is either pressure over time, flow over time, and volume over time. So that's like a scalar. And when they are over each other, like pressure over volume or flow over volume, they form a loop. So they are the loops. So we'll talk about them one by one. So when we talk about scalar, which means it's over time. So as you can see, this is the pressure over time, and mainly because we are talking of neonatal ventilation. So we are talking about pressure ventilator, because we are not using a typical volume control ventilator. So pressure control ventilator. So this is how the pressure over time would look like. The pressure would rise, and then there will be a plateau. And this plateau will stay till the inspiratory time is there, and then the expiration would start, and then it will start coming down till the next cycle will start. This is how it will be seen. And the flow over time would be like, there would be, you know, that flow. So there will be something which is flowing in, and then the thing is coming out. So the gas is flowing in and the gas is flowing out. And that's the reason the flow over time will have a positive as well as negative deflection. So the positive deflection is during the inspiration, and when we are expiring, we are taking the gas out, that will be the expiration. So there will be a increase in the flow until it reaches the peak inspiratory flow. And then peak inspiratory flow, and then it will start coming down. So you see, when it is coming down, still you can see there is a plateau of the pressure scalar graphic. So why is it happening when the flow is still coming down? So this is because there is a distribution of the flow in the lungs which is still lasting till the expiration is started. And once the expiration starts, it's going to be a negative flow until the peak expiratory flow is reached, and then it will start coming back to zero. So there is a zero where there is no flow, and there is a positive flow, and there is a negative flow. So this part is inspiration, this is expiration. And then volume over time, if you see, when the flow is increasing abruptly, that's the time when the volume deflection is very abrupt. But even when the flow starts to come down, the volume is still going up, but the pace goes slower. And there is a little plateau, and then the expiration would start, and then there will be a time when the next inspiration would start. So this is how they will look during the same cycle, how the pressure time would look, how the flow time would look, and how the volume scalar would be looking. Now, each thing would be, there will be a trigger, there will be a limit, and there will be cycling. So how do we see that? So the starting point would be a trigger point, and if it is a patient-assisted ventilation, there would be some trigger, but if this is a controlled ventilation, it will start off its own. So this could be by the flow, or it could be pressure, or if you're using NAVA, it could be EDI. And then you have to see, you have to limit yourself that you won't go beyond that, otherwise you will have catastrophe. So that limit is depending on which ventilator limit you are using. So we are using usually pressure limit ventilator until unless we combine them with a volume guarantee. So our limit is either, this is the limit where we won't go beyond it, either it will be volume or pressure, and in NAVA EDI. Then when do we stop? Like there should be a time when we will stop that much pressure generation. So that will depend on what type of thing you are using. Are you cycling with time? So you have given, if you're cycling with time, you have given some inspiratory time, and after you have reached that much of inspiratory time, it will stop. Or it's a flow cycle, then you will say that, okay, I have reached 25 or 30% of the flow, less flow, then I will stop. Or the EDI, if you have used NAVA, then the cycling will be according to that EDI. So these are very important: trigger or start, limit, and stop or cycling. Now we will take one by one. Like a pressure scalar graphic, you see, it will never start from zero. Why? Because you are giving some PEEP. So it will start from here. So there is a PEEP which will be constant all throughout the cycle. So this will straight line like this. And then you have a pressure which is going to increase during the inspiration till you reach that, what did I say? The target. So it won't go beyond that. And it will remain to that plateau till, if you are time cycling, till that time, inspiratory time is over, and then the expiration would start. So here you will get the inspiratory time from the beginning of the inspiration to the start of the expiration, and the expiratory time from the starting of expiration to the beginning of the next inspiration. So that is how the pressure scalar will look. And the flow scalar, as I said, it will have positive as well as negative. So there will be flow which will increase till it reaches the peak inspiratory flow. And then it will start coming down until it reaches 0. This is the inspiratory time. And then it will go to the negative reflection, that is peak expiratory flow. And then it comes back to 0 till the next inspiration starts. And this much time is the expiratory time. So all the positive deflection is the inspiration, and this is the expiration, and this is the 0 flow. Then the volume scalar, again, there is a start of inspiration. And as I said, when the flow is increasing fast, the inspiration is peak. And then when the flow is coming down, the inspiration is little less. But till the expiration is coming, this is the inspiratory time. And then the expiration starts, and this is till the next inspiration occurs. This is the expiratory time. And this maximum is the inspiratory tidal volume. So what do we get from each of these scalar graphics? What do we look at? So this is what we know, but what are we going to look at? So when we are looking at the pressure scale, we can find out the type of ventilation, the driving pressure, PIP and the PEEP, whether it is a sine wave or the square wave, and the trig wave. So how do we know the type of ventilation? So if we have a pressure control ventilation, the pressure scalar would look like it will be a rectangular like this, and the flow will be triangular. In the volume control ventilation, the pressure, because the volume is being controlled, so the target is the volume, not the pressure. So the pressure scalar graphic would be triangular, and the volume, the flow would be rectangular. You can see the same thing in the pressure control also, only in one condition, when the flow is not adequate. When the flow is not adequate, then the pressure scalar graphic will start looking triangular, and the flow will start looking rectangular. So you have to see, you cannot say now my thing is changed to the volume control. It is still a pressure control, but I need to do something with my flow. Then you can see the factors which are affecting the map. So this is in the pressure scalar graphic, you can see this is managed by the flow, this is managed by the time, and this is managed by your PIP, and this is managed by your PEEP, and this is managed by your rate. So you can know where the problem is occurring, and if you have a high flow, you will have a square wave, too much square wave. If you have adequate flow, you will have a sine wave. So you want to be baby friendly and more going to the physiological way of handling the ventilator. So you will always look for a sine wave and not like a square wave. So that's why you can see if it is a slow rise, it will be triangular. If it is a moderate rise, it is like a sine wave. And if it is a fast rise, it is like a square wave. So we don't want to see this. We don't want to see this. We want to see this moderate rise. Then to see the pressure scalar graphic and to know whether it is a patient triggered or it is a controlled ventilation. So if it is a patient triggered and assisted, then you will have a negative deflection, because when the patient is trying to trigger and generate, you know that we are generating a negative pressure in the normal sense when we are breathing. So this will be a negative deflection, which means the baby is the one who's triggering. And if we don't see this, it means it's a controlled breath. So this is how you will be knowing about your mode. And then to know whether it is SIMV or SIPPV or assist control, how do we know? So what is SIMV? SIMV is a mode where you are synchronizing intermittent mandatory ventilation. So you have a fixed rate which you want the baby to be synchronized with. So whatever rate you have kept and whatever inspiratory time you have kept, and you have kept a trigger. So if the baby is triggering during that 1/3 of the time of the inspiratory time you have kept, then that breath will be synchronized. If the baby doesn't trigger during that time, then there will be no synchronization. And if the baby wants to trigger during the in between the breaths, then that will also not be synchronized. So when we say SIMV, we should know that it is not completely synchronized. So what you will see is some of the breaths are synchronized, where you will see this is the trigger. Here the baby is not able to trigger, so this is not synchronized breath. So that means it is not completely synchronized. So you will be able to see in SIMV this kind of pressure time scalar graphic. And if you want to synchronize the whole thing and still continue to use SIMV, you want to support the other breaths which are not synchronized, what you can use is SIMV plus pressure support. Then how it will look. So these are the breaths which are synchronized and these are the ones which are not. So these, if you add a pressure support, so they will be supported by the ventilator extra. So then how it will look like. So these are those triggered breaths and these are the supported breaths. So this is how the SIMV plus pressure support would look like. How the assist control will look like. So because assist control is that you are not giving any number of breaths, you are just giving a backup. So you are the only thing you are giving is the inspiratory time. So the baby, all the breaths of the babies which are triggered by the trigger level which you have kept will be assisted by the ventilator. So this is how it will look like. So it looks quite nice. However, if you should know that this is not completely synchronized because it depends on the inspiratory time you have kept. So if the baby wants to breathe longer, it will get fiddle and fight with the expiration. If the baby is breathing shorter, then the inspiration and expiration will fight. So there will be some fight between the ventilator and the baby if the inspiratory time and the expiratory time is not similar to what we have kept. So, but still it is better than the SIMV as far as the synchronization is concerned. And this is how nicely in the pressure graphic it will be looking. So this is how it will look. But if you have kept the backup rate too high, then some of the breaths will still not be synchronized. So what you should do then, that you should reduce your backup rate. These will be untriggered inflations in between. So reduce your backup rate. Don't increase your backup rate too much. Then let's come to the flow curve. So this is what you can find from the pressure time. From the flow time, what you can find is the peak inspiratory flow rate, the peak expiratory flow rate, the respiratory pause or area of no flow, expiratory asynchrony or synchrony. You can optimize your inspiratory time in this flow scalar graphic. You can look at the leak and the air trapping, and you can find whether the flow was adequate or inadequate, as I said earlier. So how do you set inspiratory time with this? So here you see, you have given inspiratory time A, whatever, and you have given a PIP of 20. So the tidal volume achieved by this is 15. You see what is happening here? The flow is, inspiration is happening and then it is coming down. But what do you see? The inspiration has not ended and the expiration has started. What does it mean? It means that we are less on the inspiratory time. So what we do, see here, inspiratory time is too short. The inspiration has not come to the zero and the expiration has started. So just by changing this dead area, by increasing the inspiratory time, I just increase this inspiratory time and this lost tidal volume could come back. And you see what happened? With the same pressure of 20, the volume given to this baby is 20 cc from 15, it has increased to 20. So only thing I did was I have increased inspiratory time. So I have to be looking into the whether my inspiratory time was insufficient or not. So optimizing inspiratory time by this is important. Now the reverse can happen, that you have given an excess of inspiratory time which is going into nowhere. So there will be an inspiratory hold area of no flow. So here you have reduced a less inspiratory time, and here you have an inspiratory time which is an excess. So we don't want either of the two. We want an adequate inspiratory time when this should not be area of no flow, and here expiration should not start before the inspiration has ended. I hope it's clear, and it is very important. Then the inspiratory time is not there in a flow cycle. As I told you, the cycling can be either with the time or it can be with the flow. Now, how do we do it with the flow? So it is like it's 100% flow, and then as the flow is reducing, it's coming down, and we say, okay, the inspiration would stop once we reach 25 or 30% of the flow, and then the expiration would start. So this is how flow cycling happens. So when we do a flow cycling, we are more physiological because the baby is defining that when you need to start your expiration. But then you should be very careful what flow you have kept to cut off this. Like here, you can be wrong. If you do that, my inspiration is going to be ended if I reach 60% of the flow, then you are actually reducing your inspiratory time. Or if you go overboard and you say, my inspiration would end when I reach 10% of the flow, then you have exceeded too much of inspiratory time and you will get an exhalation spike because the baby now wants to exhale, but you are still going on and on. So there will be an exhalation spike. There may be a hypercarbia because of this. Maybe there may be autopeep generated because of this, and that's not right. So we should know that it should be at a correct cutoff. Then from this flow waveform, you can also know the gas trapping. How do you know? When the expiratory flow does not return to the baseline. Simple. So here is your inspiration and then your expiration starts. You see here, the expiration is coming to your baseline. Very nice. Here also the expiration is coming to your baseline. What happened here? Your expiration has not ended to the baseline and your inspiration has started. This means you are not exhaling, giving time for exhalation, and gas is trapping. Gas has not come out. It's still there and you're pushing more gas in. So this is gas trapping. So when you see this, this is a gas trapping. And if you have made your expiration time too short, this will lead to this gas trapping and it may lead to a auto peep generation. So this is not okay. So you are ending the expiration here instead of here, and you're generating an auto peep. Or what can happen, that it is taking longer time. This should be the normal, longer time to come here, and here air trapping and auto peep would be coming. Then how do you know the resistance, expiratory resistance, if it is increased in this flow? So this is the normal resistance. You can see here, normally it's nicely, smoothly, it is coming back, the expiration. However, if we have elevated resistance, so inspiration, is an active phenomenon. When it is pushing in the gas, the expiration is a passive phenomenon. So if there is an increased resistance, then there will be a problem and trouble to gas to come out. So it will be taking longer time to come out. So this is a sign of elevated resistance. So we should know if it is happening like this is causing a problem. And hence, how do you look at? So you see the peak expiratory flow rate is low and it is taking longer time to come back to normal. So that means there is a resistance. What do? You give a bronchodilator. So then you have to see whether my giving bronchodilators helped or not. How do you see? Immediately what you will see, your peak expiratory flow rate is increased and your expiration has come back to normal very quickly. So this is a good sign that your bronchodilator is working. Then come to the volume curve. So what we can learn from each thing we should know. So in the volume curve, we can know the tidal volume. This is the tidal volume baby got. We can know the breath stacking. We can know the spontaneous breath volume and the mode of ventilation and the air leak. So this is the volume. So what do you mean by air leak? When expiration is happening and it is leaking, coming out before the thing comes down to normal. So this is how the air leak in the volume will look like. So exhalation did not return to zero and there is a shouldering and fall from a cliff like this sign you will see. This is a sign of leak. Type of ventilation, I have already said, it will be pressure control. The volume will be less triangular. In the volume control, it will be more angular. So let's see what we learned in a real case scenario. These were all like graphics to learn, but this is how the baby graphic will look like when you will see in your day-to-day practice. So can anyone tell me, this is a pressure time, this is the flow time, and this is a volume time. What is it? We can, you can actually unmute and say also. Oh. Or you can.
We have secretion or we have some kind of resistance.
Secretion mode.
Yeah, this can be one, but what is happening here is, you see, the inspiration has not happened and expiration
time is prolonged.
Yeah, so we have a inspiratory time which is less. If you see here, and if you divide it in between, your inspiratory is less and your expiration is longer. So you have a shorter inspiratory time in this baby, right? Leak, I don't think so there is a leak. So this is a shorter inspiratory time. So now what we do, when we have this, we will increase the inspiratory time. So here I increase the inspiratory time by decreasing the rate. I did not touch. So when I decrease the rate, my inspiratory time will automatically increase. And you see, now it is trying to come to zero. Still there is little space and I can still increase the inspiratory time further. And if you see, in the volume also, you will see the inspiratory time has improved. So this is how you can see in your real-time graphics. See another one. What is it?
Prolonged eye time.
Yeah.
Because the inspiration has finished while still there is some area with no inspiration effort.
So the typical what we saw there is a area of no flow. So this is very dangerous because now baby is trying to exhale. You are actually compromising on your expiratory time. You will lead to auto-PEEP. You will lead to hypercarbia, and you will lead to work of breathing as well. So this is also not right. So what is happening here?
Shouldering.
Yeah.
Auto-PEEP.
Yeah. So again here, your expiration is not reaching the 0. So here your expiratory time is less. And this is leading to your autopy. So you have to, and if you see here also, how to see is the deflection, the expiratory deflection changes. And if you make a line straight, you will see that the expiratory time is less. And here, the expiration is not reached the 0. So here you have to increase your expiratory time. So
how would you increase the expiratory time?
To drop your heart rate.
You mean to reduce the
Or
inspiratory time so that expiratory time will increase?
Yeah, you can do that, or you can, yeah, you can do that, and you can change the rate. So,
Change the rate.
yeah, you can change the rate to make it that. Then you may have something like ineffective triggering. When you say ineffective triggering, when you can see that there is a drop in the pressure where when the flow is increasing and there is no following ventilation. So this is a wasted effort which is going to happen. And this can happen when you are not given a proper trigger for that particular baby. So you need to give a proper trigger to that particular baby. Otherwise, you will have this kind of a wasted ventilation, ineffective triggering. And then sometimes you may have double triggering. This will happen when your baby is too...
Dr. Monica, or good sedation.
Yeah.
Right? On the previous slide?
Yeah.
Or a good sedation, if you don't want to change the trigger.
Yeah, that can be done here. And the double trigger will happen if your baby is very strong and producing lot of, has lot of inspiratory efforts and has a longer inspiratory time than the time you have kept on the ventilator. Then it may happen that baby is going to double trigger. So this is not going to end, expiration is not going to finish, and then another inspiration is starting. So you have to see that that means this will be one indication that you have to adjust your inspiratory time for a longer time so that the baby efforts are more, and depending on that, you may have to change your inspiratory time. Then we'll come to loops. So loops are when two variables are plotted simultaneously and you look at their interrelationship. So they will be the beauty of loop is that the starting of inspiration and end of expiration coincides at single same point. And you should see your ventilator because there is no agreement that positive will be always inspiration and negative will be always expiration. It may be opposite. And clockwise and anti-clockwise things may be opposite. So you should know your ventilator and your graphics when you are buying and seeing where it is, because otherwise if I will teach you this way and you will start looking at your graphics the same way and it may be the opposite one, then it will be a problem. So you should see that most of us have that upper label deflection is positive and lower is negative, but it may be the opposite. So that is to be seen. And what is the use of these loops? We can look at lung getting over distended. We can know at airway obstruction. When we have given bronchodilator, we can know the response. We can know the respiratory mechanics, the work of breathing, flow starvation, the leak, and the triggering effort. So everything what you want, you can see in this loops. So as I said, there are two loops. There is a pressure volume loop and there is a flow volume loop. So we'll take one by one. So pressure volume loop, in that the pressure is in the x-axis and the volume is in the y-axis. And as I said, we are not supposed to see it starting from here. It should be starting from here because we are going to give some PEEP. If you're starting, your loop is starting from here, that means your PEEP is not enough or you have not given it properly. So it should start from here. And if you are using assisted ventilation, you will see a trigger and the triggered reflection will be going in another direction. So that will be a clockwise direction. And then the ventilator will start giving, that will be in an anti-clockwise direction. So here the pressure is increasing, but the volume is not increasing that much. But till you get the inflection point, the lower inflection point, when suddenly the pressure increase will lead to increase in the volume, till you get this plateau, and then we'll start the expiration. And then the expiration is slow, and then comes a expiratory deflection, where the PIP will fall abruptly, and so will fall the tidal volume. And when you join these two, this will be giving you a compliance. So compliance is nothing but change in volume with the change in pressure. So this much change in the pressure is causing this much change in the volume. Looks quite nice. So in the real sense, when you see, this is how it really looks like. And this plateau in the pressure time scalar graphic is here. And this is the dynamic compliance. So if it is baby who's breathing spontaneously, this is how it will look like, because the inspiration, as we said, we are producing a negative pressure, and this will how the expiration would look like. And it is all clockwise only. There is no anti-clockwise. In the assisted breath, first it will go clockwise, and then it will go anti-clockwise. And this is the inspiration, this is the expiration. So the resistance, how do you see? The deflection point of the inspiration, if it goes wider, this will go wider, and this is inspiratory resistance, which is increasing. And expiratory deflection point, if it goes wider, this is the expiratory resistance. So this is how you will see the resistance. In the center, you will see the compliance. And they don't have any correlation with each other. Compliance may remain the same, and the resistance might increase. The resistance may remain the same, and the compliance might reduce or increase. So you should know where to look for. So when we look at the PV loop, if you see this A, B, C, A, this is the frictional resistance during the inspiration. A, C, D, A is a frictional resistance during expiration. And A, C, E, A is the elastic resistance. A, B, C, A all is the total work of the respiratory cycle. So how do you find which mode of ventilation you are in? So one, we said that we can find in the scalar graphics. Also, we can find in the PV loop. So what is happening in the CMV? The controlled breaths are happening, and if we have not sedated our baby, baby will breathe of his own, and the ventilator doesn't bother what the baby is breathing. So there will be a breaths of the baby in between, and the ventilator is going independently, absolutely. So you'll get this zigzag kind of thing. You won't get the zigzag if the baby is totally comatose, asphyxiated, or you have sedated, given muscle paralysis. Otherwise, it will look like this. SIMV, as I said, the number of breaths which we are told that it will be synchronized with the if baby's triggering during that, they will be synchronized. But some of the breaths in between, if the baby is taking, which is out of that inspiratory time, out of those things, then the baby, those breaths will be seen like this. And if we have totally SS control, then all the breaths are going to be synchronized like this. So this is how you will be able to know what mode of ventilation we are in. Then compliance, how to see. So if we have a steeper compliance like this, we are joining from here to here, then if it is steeper, its compliance is better, which means that little change in pressure is causing a lot of change in the volume. So if you have a horizontal this compliance, means it's a poor. If we have a steeper one, it's getting better. This is how we can know. And the other thing we should know is over distension. Now, how do we look at the over distension, which is very important? So this is a PEEP. This is the alveolar recruitment. This is the optimal compliance till here. But if you see this beaking, this is alveolar overdistension. So one is when you physically see the beaking, you can know it's by eyeballing, you can know there is an overdistension. The other way objectively to look at the overdistension is something called C20 by C diam, which means that the last 20% of the time of the compliance, what is happening as compared to the, so this is the last 20% of the compliance, and this is the total compliance. So what is happening between the two? So if we have overdistension, then the last 20% will have lot of pressure change and very little or no volume change. So when you do C20 by C diam, what will happen? That it will be very less. So less than 0.8 of this, that you are changing so much of pressure, there is hardly any change in the volume in the last 20 of the cycle. So C20 by C diam is less than 0.8, which means it's an over-distended lung. This is how, one by eyeballing and one by this, you can know. So if you are in the right place, you will know that a same change in the pressure will cause good change in the volume. If you are under or you are over, the change in the pressure is going to cause less change in the volume. This is 50. The same here, if you are in the right track, is 100. If you are overdoing, it is just 50. So you should know that you have to maintain your baby in the normal FRC. Higher FRC will cause overexpansion. Lower FRC will cause atelectasis. Same, I'm giving this with a number, that tidal volume produced in the lower FRC is only 1 ml with the same change in the pressure, and it reaches to 4 ml per kg if you are in the right FRC. And if you increase the FRC, again, the tidal volume is going to be less. So optimal FRC also you can find from this PV loop. So see here, if you see the compliance when it changes, if you have a baby who has RDS, surfactant deficiency, or baby who has fibrosis, hyperplasia, so the compliance will not be on the horizontal size. So change in pressure is going to produce less change in the volume. If you have given surfactant to this baby, the small change in pressure is going to produce large change in volume because the compliance has improved. If you see emphysematous lung also, though the alveoli are less, but they are very fragile. So even the small change in pressure will cause a lot of change in the volume. So we should know that when you are looking at the emphysematous lung or you're looking at fibrosed lung, the compliance is better in the emphysematous lung, so please don't overdo it. And the compliance is poor in the fibrotic lung. So, and the deflection point remains the same in all these conditions. The lower deflection point as well as the expiratory deflection point. That means the resistance is okay, but the only thing which is changing in them is the compliance. So let's take an example, a 27 Wk Preemie 850 gram, whose compliance is 0.3 ml per centimeter of water. And you have put the baby on SIMV mode of ventilation, and you have kept RR of 60 and PIP of 26 required, PEEP of 6. And you have got this blood gas, which is causing a lot of CO2 retention and little respiratory acidosis. If you look at your PV loop, what is happening? So much change in the pressure is causing only this much change in the volume, and it is quite horizontal. So it's a very poorly compliant lung. What will you do?
Surfactant.
So we will give surfactant. So now we give surfactant, and see the beauty of giving surfactant. Suddenly, your compliance has improved. It's become steeper. This much change in the volume. Pressure is falling. Huge change in the volume. And you said, okay, let me come down on the pressure, and you just brought from 26 to 24, and you gave the tidal volume 20 ml per kg, you know.
Can I ask a question?
Yeah.
So why you're giving 0.8% of I2 and then 0.5? Is that like acceptable for you, or what like 0.8
No.
I saw first slide and then 0.5?
No. This is someone's thick, which started with 0.8 when baby was so poor till they started giving surfactant, and when they gave surfactant, they brought down to 0.5 only. So that's just a example just to say that, okay, from when you gave surfactant, you came down to FiO2 so much, but I'm not going to wait for 80% to give 80%. I'm going to give surfactant when I'm 30% of FiO2, more than 30 if I'm reaching.
Okay, just like a teaching point for those reading it.
Yeah. So I will not, so I didn't, that's why I didn't want you, I didn't emphasize on that. My main emphasis here is, you know, that I did not come down on the PIP so much. I came down to 24 because I didn't look at my PV loops. I didn't have my volume targeted ventilation with me, and I got my blood gas, which is showing CO2 of 25. And the next thing I got is this and this. So the which is we don't want. So what the beauty that when we look at this, we can come down on our pressures, or I will talk later, we can use our volume guarantee to bring down on pressures by its own. So how we can look in the PV loop that the treatment is effective, and so we should do something. And see here, the beaking has also started in this. Yeah. And so this happened. So how do we do that? This is what I'm coming to, that you can come over this by using our preset tidal volume. And so as the compliance is going to change, the pressure which will be given will keep on changing. So when my baby was not good and compliance was bad, my ventilator was giving this much of pressure to get that much of tidal volume. And as my compliance is improving, the pressure is decreasing by its own to reach that much of tidal volume. So now this is the beauty of the volume guarantee or targeted tidal volume kind of mode, where you can, the pressure by the ventilator is going to reduce by itself as the compliance is going to improve. The next thing what you can see in the PV loop is the air leak. So air leak just means that it's not coming back to zero and it's leaking somewhere. So here it is. So it's leaking here, and this is how you can pick it up from the PV loop. And we could pick this air leak again in which one? Which other scalar graphic? If people are listening. And,
volume.
Yeah, volume. So, so you should know where to look for what. And then flow starvation. So when you have a flow starvation, this will look something like this. Cusping will be there. And as I said, whenever you have flow starvation, the pressure time scalar graphic would start looking triangular, and the flow scalar graphic would start looking rectangular. That means we have a flow starvation. So these three places we will be looking for a flow starvation. Then how do we look at resistance? As I said, inspiratory resistance will be increased if the lower inflection point is going wider. Expiratory resistance would be by more if the upper deflection point is going wider. Then comes our flow volume loop. Now, this is the most one where, you know, different ventilator will show the positive and the negative maybe on the opposite side. So we should be very careful on that. As I said, starting point and the end point is same. So here we have started, the y-axis is the flow and the x-axis is the volume. So the flow is increasing, and then the volume will, with that, the volume is going to increase in the inspiration. And we have reached the peak inspiratory flow rate, and then it will come to zero when it will start expiring, when it will be negative, and then it will come back to zero. And it will start from here. This is the FRC. So this is how the flow volume loop would be looking at. Like, now what will you look in this? Again, we want to know which mode of ventilation we are in. Same, synchronization is the only thing which will you have to see here. Again, in the CMV, baby is breathing off his own and the ventilator is giving off its own. So this will look something like that. In SIMV, as I said, the synchronization is happening only of 40 breaths, what you have chosen. The rest of the breaths or some of the breaths even between that 40 which are not able to trigger or which are not falling into that inspiratory time, the baby is breathing off his own. So it will look like this. And in SS control, all the breaths would be looking like this in the graphic. Then what we can find here is air trapping. So air trapping, we were able to find in another, was in which scalar graphic?
Flow.
Flow, yeah. So the other place where you will see the air trapping is in the flow volume loop. So what is happening here is it is not going to zero and it is ending here. So this is air trapping which is happening. As I said, in the flow also we could see the air trapping where it is not going to zero and the inspiration has started. So this is air trapping and this is going like taking longer time as well. So this is the air trapping. Air leak. So this is coming to zero much before the time. So it is just going out much before time. This is air leak. And we said we can see the air leak in the, where all?
Volume.
Volume.
And other loops.
And the PV loop, yeah. So we can see the leak here in the volume where you cliff, shoulder cliff like thing you will see. In the PV loop, it's ended much before. And here it is ended, expiration has ended much before. Expiration has ended much before. So this is the three places where you can see the leak. So when you see in all the three places, then you are more certain that there is a leak. Otherwise, it may be just an artifact. So that's the thing. Then the airway secretion or the water in the circuit. This will be seen like this zigzag during the expiration. It will not be seen in the inspiration mainly. If it is too much, then only you will see in both the places. And when you look at here, there will be a lot of secretion. And when you did the suction, this is clear and this also cleared here.
Or in the circuit.
Yeah.
Or water in the circuit will give the same shape.
Yeah, but no, if it is in the circuit, so first thing whenever you have this, you should first look at your circuit. So if you see water there, you should remove the water from there. You don't need to do a suction on the baby. And it would be okay. But if you don't see any water in the circuit and you see this kind of thing, then you will look for a secretion and then you will do the suction. And then if you have an airway resistance increase, so this will be actually scooped out pattern. And another place where you could see the airway resistance increase was?
Scoop out.
Which is scalar graphic, you could see the volume, resistance increase, and we had looked into the bronchodilator effect as well.
No.
Flow.
No.
Yeah. So we can see in these two, like if you see here, this is normal, but here it is scooped and there is a bronchospasm. We gave some bronchodilator and it became normal. Same if you see in the flow, this is peak expiratory flow is less and it is taking time. Here also if you see peak expiratory flow is less and you gave a bronchodilator, the peak expiratory flow rate came to normal and it came back to normal, you know, early time. So this is the response you can see. So you can see the problem and you also when you treat, you can see the response. Let's see the live examples. Oh, I've already, this has come, I don't know why. So what can you see? What do you see here?
Air trapping.
Yeah. So we can see that if you see in the flow scalar, the expiration has not ended and the inspiration has started. So you're air trapping. The expiratory deflection point is turned like that. And here also, this is not returned to 0. It is from here only. It is
below 0.
So this is air trapping. So you can see air trapping here, here, and here. So what do? You will try to increase your expiratory time. Yeah.
Don't you increase your PEEP when you have air trapping?
Your PEEP,
Yes.
it will cause an auto PEEP by itself, the air trapping.
Reduce the rate.
Yeah. So what's happening here? I don't know why these are coming by itself. I would have
Increase the PEEP. If you increase the PEEP, will solve a little bit of the problem.
Yes.
I agree with him. I don't know. Sorry for interrupting.
Yeah.
I do that sometime and it solves the problem sometime.
Okay.
I like very high PEEP, by the way. I reach 16 and 17. So, and sometimes I reach 20 PEEP. So, yeah, I like PEEP. So I don't like PIP. I like always PEEP.
No, anyway, we all would love PEEP rather than the PIP, which will cause volutrauma, barotrauma. And that's why we go for high frequency ventilation, where we can give the maximum PEEP and, cause less this thing. So what happened here?
Short eye time.
Yeah. So we can see that the inspiration is not ended and expiration has started. The inspiratory inflection is becomes steeper and the inspiratory time is less. And here also it is not where it should end. It is ended much before and the expiration has started. So these
and scooping on the pressure.
Yeah. Yeah. So you can see the smaller, the pressure scalar thing is very small. So you will increase your inspiratory time by changing your lead. And here, again, there is an shorter expiratory time. What's happening here?
Yes.
Trapping.
Some leak.
So yeah. So
some degree of leak, like 30% leak.
Yeah. So there is a leak here. You can see this here is N0 before time, and here also it's not coming.
So, but the leak, the numbers are not there. It's only like 3. If you see the tidal volume in and tidal volume out, there is no much difference.
So because there is an leak compensation maybe going on.
Probably. Yeah. Probably.
And here?
Secretions.
Yeah, so we have secretions here. And what's happening here?
Pasteurizing?
Huh? No, not regard.
Prolong expiratory time.
Expiratory time, yes.
Yeah. So that is what is happening. Kind of, and little bit of auto triggering is also happening here.
Is this a SIMV plus pressure support ventilation? No.
Yeah. Yeah.
It is? It is. Okay.
This is this is the pressure support.
Yes.
And these are like these are hiccups actually.
Mm-hmm.
Because rest everything is fine. These are hiccups, and because of the hiccups, sometimes you may have this. So you should go and see the baby when this kind of thing we are seeing.
Yes.
Causing a kind of an auto trigger also, these hiccups.
Mm. Yes.
Again, the expiration is prolonged.
Mm.
Yeah. That is what is happening.
Yeah.
And then you are actually decreasing, then see it's like actually reduced, I think, too much. So we have to see.
Isn't this low base flow? or tube resistance, which causes this. See, if you see the flow volume curve, it's very prolonged. This goes with low base flow in the settings.
See, if the flow is less, we will be seeing this as a triangular and this as a rectangular, which is not happening. So that's not the point here. That's not happening. Flow is fine. So sometimes what you will see like this, when will you see this kind of thing?
Low trigger, I think.
No, this is like tracheomalacia, you know?
Oh, I see. Okay.
Yeah. So you will see like this and here. So this is kind of tracheomalacia, airway obstruction due to tracheomalacia. So sometimes when you're not able to wean the baby out, so this could be reason. I'll give some examples of the patient ventilation, interaction, and volume guarantee, because all of us are using volume guarantee. 2-3 slides on that and then we can end. It's fine?
Yes.
So what is volume guarantee? As we said earlier, that we are going to, we are on the pressure control ventilation, but we don't want any kind of volume trauma. So when the baby's compliance is going to improve, we want the pressure to change and deliver only that much volume what is required by the baby. So in that, what we have, that's why it is saying volume guarantee. So that you will choose a volume between 4 to 6 ml per kg, depending on the baby. And then you will keep a particular amount of PIP. And then you will keep another thing, which is, one is the working pressure, and the other is that you will keep a 5 centimeter above that pressure, where if something, the compliance is less and the patient needs to be given more pressure to achieve that much of volume, it can be given. So that when the baby is improving, the pressure is going to reduce by itself to give that much of volume. That is the volume guarantee. And so the breaths, the previous breaths will control the pressure of the next breaths. And each ventilator is doing it in a different way. Like Draeger takes average of 2 to 3 breaths, and the SLE does in a different way. So you should, but the main principle is same. So if you see here that the targeted volume was reached, and so the ventilator know that this much of pressure is enough to achieve this much of target volume what we have set, and so the next breath it will give the same pressure. But then something happened to the baby and the targeted volume achieved was less, and so the ventilator came to know, oh, this much pressure is not giving that much of volume, so it increased the pressure. So when it increased the pressure, and the volume came same, so that it continued to give the same pressure. But then the volume increased somehow, and the ventilator came to know, so it reduced the pressure. So it is trying to change the pressure on the base of the volume which the baby is actually getting, which is very beautiful. So this is how.
Can I just ask how is it different from the usual volume ventilation?
Can we leave the question at the end? Is that okay?
Yeah, that's okay.
Okay, we'll take in the end, yeah.
Let's take it in the end.
So what happens is, it's like a self-weaning. You can see that as the compliance is improving, the PIP is reducing by its own. Very beautiful it looks. So compliance is improving and the volume is reducing. So you need to keep upper limit of PIP. Usually we are keeping 5 centimeter of water more than PIP. But if it is a very small baby and you are worried about the trauma, you might keep sometimes 3 only to have that working pressure with you, so that it doesn't overshoots just because it's not picking up in a right way and we go for a volley trauma. So to prevent that, you might choose only 3. And and for the volume also, there is a like 130% more is the limit for the volume which is kept, and that limit can also be changed depending on your baby. So we know that the sick baby is different from a healthy baby. So if a sick baby with a compliance of 0.2 ml per centimeter of water, and if you're changing a pressure of 5 centimeter, it will generate tidal volume of 1. Whereas a healthy newborn who has a good compliance of 2 ml per centimeter of water, if you change a pressure of 5, it will generate a tidal volume of 10. So this should be very well kept in mind.
How long you have more time? It's like 1 hour, 10 minutes now.
Finishing.
Okay.
So I just want to say that, the upper limit of the tidal volume, how to keep it should be like 130% of the target, and then it will give. So you have, if you have, supposing if you are setting a VG too low, and the baby is wanting 6 ml per kg. This is important. Then what happens? That baby, if you are keeping 4 ml, baby wants 6 ml. So baby will generate its own this pressure, and the ventilator will keep thinking that it doesn't require, so it will keep on reducing the pressure. And then the work of breathing for the baby is going to increase. So this is important to be kept in mind. And then again, if baby has no efforts, okay, you are giving, you have set a tidal volume and you are getting that much of pressure is generated to give that much of tidal volume. But if the baby starts having efforts, so it's got a lot of tidal volume generated, and so the ventilator would start reducing the pressure of its own. And when the baby gets no efforts, then you will get less pressure and the less tidal volume. So this is what I wanted to say, because also you should know that the triggered and non-triggered breaths are looking into the tidal volume in a different way, and so they have a different control to generate the tidal volume. So these are the triggered and these are the untriggered breaths, so they are different. Another thing is, what I want to say is the low backup rate and a high backup rate. How does it differ? So if you have a backup rate which is very less than this backup rate, then you don't have enough time to trigger and your PIP is going to reduce. And if your backup rate is equal to the backup rate of the spontaneous breathing, then baby doesn't have any time to trigger and you will have a higher PIP. So the backup rate is very important, that you should keep an appropriate backup rate. So thank you. These are the few things I wanted to highlight, which is like a fine tuning of the ventilator with the pulmonary graphics. I'm happy to answer questions.
Thank you very much for the lesson. It was very interesting, very long, but it was very, very well presented. Thank you very much. I really appreciate it. So why we don't start with the last question of, I think Muhammad was asking.
Yeah. So as I said, the volume control ventilation is controlled by the volume itself. So that means that it is the cycling will happen when you reach a particular volume only. But in this VG mode, it is still pressure controlled, and you are adding only volume to it to change the pressure to get that it's that much of volume. So it's still pressure control. It is not volume controlled. That the volume controlled ventilation is absolutely volume control when you will keep the volume as a control. So that's how it is different. In the
Okay.
pressure control ventilator is just added a volume guarantee with that.
Thank you. Any more questions? Any question?
Would you make another lecture for HFO figures?
Yeah, we didn't take HFO, so we can, we can take, actually when we take HFO, we can take the figures in that only. Which
Yeah.
will,
Excellent.
yeah.
Thanks.
Okay. So I do have one comment. I think using loops and graphics are very essential in the state-of-art ventilation. When we do gas, how many gas you can do? Like every hour, that's 24 numbers. Every 2 hours, that's 12 numbers. But you have loops and graphics, it's continuous. So if you combine it with other modality of monitoring, it's a beautiful way to monitor the baby. And when you select numbers and modes in 30 minutes ago, after 10 minutes, everything will change because the ventilation is dynamic and your setting should be dynamic. You should never depend on number. You should not never give like remote orders. Those people who's carrying these babies 24 hours should know what they're doing when looking to these numbers. You don't need to go in deep in it, but at least like general principle would help you to ventilate. Now, I'm not saying that doing gas is something bad, but you should not only depend on the gas. These monitors are having beautiful loops and graphics and many numbers, and then you need to use them. So this lecture was very important and needed lots of training and discussion.